This is as good as it's going to get. So I really wanted this episode to kind of come later on down in the sort of episode extreme, if you will. The reason for that is pretty simple because I considering what I'm about to talk about, one would think that when you make a podcast that's based in many ways and sort of founded on the basis of brain and that being inspired by my story that I'm about to tell you with my tumor, you would think that it would be episode 0, right, or episode 1. But I'm generally new to all this, so because of that, I wanted to make sure that I had at least a somewhat general idea to do the story justice. Mostly because I think there is a ton, and I do mean a ton of value that people can and will get out of this. Simply put, what I put in my video title is very much true. I shouldn't be here. I should not be breathing. I should be 2 years in, maybe a year and a half in on decomposition. So this is going to be a very interesting topic to talk about, one that I'm sort of excited to talk about. I'm always a little too excited to talk about this topic considering what a wild journey it was. Aside from that, I do want to start off with a disclaimer. Because of the nature of what I'm going to be talking about, it needs to be understood that, one, everything that I'm presenting here is going to be educational. Therefore, and hopefully it doesn't get censored, blocked, moderated, and taken down, whatever the case may be, if there's some sort of community guideline strike. I know I've seen things far, far worse in terms of visuals and accessibility as it pertains to medical related stuff on YouTube. So I know there is a pocket for this kind of thing. Whether or not I am going to be trespassing outside of that, I don't know. So that's one. And then two, I understand that people can have varying degrees of stomachs and things that they can find tolerable, especially with this sort of story. I have come across people who I've told that have thought it was extremely fascinating, really cool. Some people that were sickened out. Some people have spun into panic attacks and, just not a good response to hearing, what I'm about to talk about. And since we have to account for such a wide scope of people that may or may not watch this video, well, I guess if they're not watching the video, we don't have to account for them. But regardless, so one, if you're someone who cannot handle, talking about medical procedures or anything like that, because it'll give you a panic attack. Trust me, I understand. Used to have them really, really bad. I still sometimes have them as it pertains to this topic. So, if that's the case, maybe this is not a video you want to watch. Just because, like I said, I've talked to people in person. I've talked to medical staff who I've given sort of panic attacks over their own well-being. And it wasn't intentional. It's just reality, right? And that's what we're going to talk about. We're going to talk about reality. We're going to talk about something that's real, something that I experienced, and something that other people experience and they don't survive. Or they survive under much worse conditions, or they're dealing with something far more complicated than what I dealt with. I know you're sitting there probably thinking, like, how does it get worse than a brain tumor? There's ways, for sure. And, one of the things we'll talk about a little bit is the type of tumor that I have. And it is not cancer, but that doesn't make it any less fatal. When it was discovered for me, it was already knocking on death's door. So we'll get there. I did put together some notes on this. I started really doing a lot of notes on it. I realized in my typical fashion, I was getting way too granular in detail, especially when these notes are just supposed to kind of keep things moving. So in that regard, there's a lot to talk about, and I do mean a lot. But I don't want to, fire hose people and sort of turn them away because of how overly saturated it is in detail and medical lingo and what have you. So I am going to try to break this up into a couple different parts, and potentially I may do a summary episode that just summarizes things. But again, I think that this is one of the most important stories that I will tell. And that's coming from a guy who survived, childhood abuse, neglect, Iraq. I have some stories that are quite fascinating long before this happened. But this, I feel like, is sort of, for good or bad, this is sort of one of my magnus opus as far as it pertains to life experiences and stories. Hopefully I don't have to experience anything beyond this anytime soon. But I would often tell people who would start to maybe look at me in a way that made me a little uncomfortable, and they would look at me as this inspiration, right? As this person who is like a paragon of resilience. And while I appreciate people seeing me like that, it does make me a little uncomfortable. But I also have to remind them, and I'll remind everyone watching here, none of us make it through this thing that we call life free of something. We all have a battle. Some of you are fighting now. Some of you are fighting battles that, may seem so absolutely small in comparison to this. I sometimes feel like mine's small in comparison to other people's battles. It's the battles we fight are ours. We have a different relationship with them than we do when we're looking at someone else's problems. So it's just something that I would say, keep in mind, that the way you're going to feel about your own struggles, your own medical journeys, your own challenges in life and problems, don't try to measure them up against other people's. That was one thing that back when I was in a support group, I would often offer a lot of supportive advice. And, I saw a lot of people really driving themselves crazy. And, there was some little, like rules of sanity that I would give out. And, one of them was never compare, your outcome, your process, your journey to someone else's. It's uniquely yours. And compared to someone else will just put you into a place that's a bit of a quagmire, and you probably will not escape it. It will just spiral you into a really terrible mental cycle. So I don't recommend that. That being said, so let's hit this thing and see where we land with it. If you, like I said, if you can't handle this sort of stuff, because there will be pictures, I'll give a warning before I show pictures that may or may not be graphic. It's hard for me to tell because, again, even the pictures that I don't consider graphic at all might upset some people. So I'll just give a warning, and if you need to skip, feel free to skip. I'm not particularly good enough at YouTube yet to tell you exactly what time span to skip to. I suppose that would have to be more done as a voiceover or done in editing, but we'll see. So the first thing we're kind of looking at here, I labeled as the equation of death and life. So this was, I did this a couple years ago, I think. So this is a ChatGPT calculation that I asked for. And essentially, I fed it my medical records, right? Which included operative notes, included, post-care notes, provided a lot of data in combination with my own, I don't necessarily call it testimony, sounds too legal, but my sort of version of events, how I experienced them and what I knew may not necessarily be in the notes. And this was sort of the equation that it came up with. I just wanted to find out how many cases per year would you run into a situation like mine, where you have all these complications that stack on top of each other. And I had known, because I never had any major health issues until I dealt with this, never had any major surgeries, anything like that. But I had known that just based off of things I've read in the past, that, clinical outcomes, prognosis are very much determined by complications, right? It's not usually the initial surgery that will get you. It's usually complications. And it's not even usually like 1 or 2 or 3 complications. It's when they start to sort of, become a snowball effect. And I had a snowball effect. I think I hit just about every complication you can have. And I do mean just about every complication you can have. And I'll talk about them all in depth and how I dealt with them. And then, maybe it'll help someone else out. But the key thing is that the person would have to have all these complications in the way that I had them, and then survive, right? Like that was the key limitation. You had to survive this this process, this sort of encounter. And when I did that, I came up with this math. Now, of course, if you know anything about math, you would know right off the bat, just looking at this, it's pretty ridiculous, right? At the baseline, you need 23 orders of magnitude Earth-sized population before expecting a single individual to have all those complications and survive. But for me, I obviously had it. So let's take a look at the actual number. And there you go. That's what it takes. Right? That is obviously an insane ratio, right? Like basically that says that I shouldn't be alive, right? I should not have survived that experience. Likely strongly seems to indicate that I am the only one to have had these sort of issues dealing with this type of tumor and survive it as I did. Which is pretty crazy to think about, right? That you're sort of an uncharted case that, everyone I talk to, all my surgeons, all my doctors, and then, my main surgeon is most likely the top surgeon for this particular operation. Well, two of them really, one for neurosurgery, one for neuroenterology. So an ENT surgeon, brain surgeon. Obviously, they have teams of surgeons and what have you that assist in these sort of things, but even when I spoke to them and they, I had their personal number and they would call me while I was dealing with my complications after the first surgery. And, they didn't know what to do with it. Right. It was interesting because I got to watch, very high level surgeons, groups of surgeons, teams of surgeons sort of arguing with each other and getting on the phone and getting, fairly heated about how to handle this because, it was uncharted territory. And I'm not sure if those doctors, so the ones that I used for my initial surgery is Dr. Friedman and Dr. Schwartz out of UC San Diego. Again, they have a team under them of varying levels of experience as it pertains to both surgery and medicine. They have people that are, helping them out and being assistants that are, probably still in there later. So I just had noses itching so bad. Promise it's not cocaine. But they had people as early as they look like kids to me, but they were, wrapping up some of their final years of graduate school. And, they would help out with some of the more basic things. Obviously those aren't the people they're giving a scalpel to. I hope not. I don't know because I was unconscious. But then, they have obviously teams of world-class surgeons that work under them that are operating on you. And they themselves are obviously going to be the people that do the most intensive, the most risky, complicated aspects of the surgery. And those that work for them are going to be watching, obviously, to hopefully one day take over and do the same thing or develop their own plan. And again, another disclaimer, I have to say this in every video. During one of my complication surgeries, they did saliva glands, one of the largest ones that you have. It's the one responsible for primarily all the saliva that's produced when you're at rest. And I didn't know there was a difference between rest and not at rest, but there is. Therefore, I get dry mouth a lot when I'm speaking. And so he's even taking a sip. That's what it is. I'm not trying to be rude. I just simply cannot produce saliva anymore. I can also not produce tears anymore. I don't know if you can see from my face. I also have quite a bit of paralysis on the left side. I'm going to say quite a bit, actually. A lot of it's bounced back, but it's definitely not what it used to be. So, there's some issues with the left side, but I think it could be worse. I know it could be worse. So that's the number. And I think, again, it was important to include this and the math. Now, if you don't agree with this math and you think there's something flawed there, you're welcome to. Just take it up with ChatGPT. Not me. I didn't come up with this. I don't have access to the data sets to even begin to even form the basis of the formula, more or less actually understand the formula that would be necessary to come out with an accurate number. So that's that. So take it up with OpenAI if you don't like the math. So clearly we made a mess of our notes at some point. So I'm going to move this. So again, the notes aren't going to be totally complete. What I wanted to do though is kind of give an idea of the type of tumor, just do a quick check to make sure it's showing up well in video. So yeah, really kind of forward the notes here. I don't know what happened there. Anyways, so the type of tumor, it is actually the rarest brain tumor you can get in the base of the skull. So that might indicate why we're just starting off with an extraordinarily low, like crazy number that we're going to end up with survival rates. This particular tumor is a very fascinating one because its most technical term is a vestibular schwannoma. More generically, they'll call it an acoustic neuroma, right? So if you're not familiar with the way that medical literature works, it's very heavy on prefixes and suffixes, right? So what you'll notice here is the oma, right? So oma is generally massive tumor. And then whatever they're attached to is going to tell you what tissue that's affected by. You see this with a lot of different medical lingo. So like itis, for instance, right? Itis, cardiitis, periditis, I don't know, anything else, right? Diverticulitis, right? Those are, again, all just how the medical term works. It's handy because it gives you a general idea just by reading it, what you're dealing with, right? So vestibular, we know that that is the inner ear, right? The vestibule, which is the middle to inner ear. A lot of people don't know you have 3 layers to the ear. Ears are quite complicated. And then a schwannoma, a mass on the Schwann cells producing the mass. And what is a Schwann? Schwann, it's a fun word to say. That was a fun word to say. A Schwann is a type of cell that grows along the nerves as a sheath. So I'm trying to remember. I did do a few pre-med courses back before I decided that engineering was more my jam. I was going to try to go to medical school at least. I just found medicine very interesting, which, worked in my favor. Don't get me wrong, but I'm not going to sit here and say that I have a ton of medical experience and that's the only reason I survived this. No. If anything, that may actually be a problem, right? There's an old saying that doctors think the worst patients, and I could see why, right? So that's how that works. So both of these work. They're interchangeable. Vestibular schwannoma or acoustic neuroma. Acoustic, not meaning your acoustic or guitar, but the acoustic as it pertains to hearing and sound, and then neuroma being nerve, right? So they both work. So this is actually technically considered an inner ear and skull-based tumor. I believe what they will call this is a cerebropontine angle tumor. So cerebropontine meaning cerebrum, pons. So that general area of the brain. So you're talking about the base of the brain towards the brain stem. Now, to give some visuals here, we're going to go ahead and start off with the first picture. So again, fair warning, if you can't handle stuff like this, this would be the time to consider skipping. What we're going to do is we're going to take a look at the MRI that first caught this. What is going on? Why am I getting like 2 things moving over? Here we go. All right. So this is I don't know what's happening here. I think I totally messed that up. Hold on. Bear with me. We're having some minor technical challenges. These windows are just way too big. Something I had to adjust for on a massive screen. I want to make this sort of fair to everyone, regardless what resolution you have. So just doing some tricky works here. So this is it from a sort of front, right? So cut the brain or cut the head, right? Like in half, go, what they would refer to as the sagittal plane, right? I believe that's sagittal, cutting it, sort of posterior to anterior. So this is towards the back though. So this would be like right here. I actually told this thing to stop capturing cursor. So let me turn that back on just so that, we can see what I'm talking about here. So this would be kind of the back, right? So this is towards these 2 right here, known as your ventricles. I believe that's possibly the first and second ventricle. Don't quote me on this. I'm not exactly, a doctor. I don't 100% no. But these should be right here. This should be the end of the ear. I think this might be some of the end of the inner ear over here, and over here. We're just basically past the inner ear structure, so you're not seeing it. Which, first off, right off the back, what you can notice is that there's no symmetry, right? And that's something that I learned that I was not expecting, right? There is not symmetry, and there is symmetry. Do not expect symmetry, all right, when it comes down to your body. You're going to have some sides that are bigger and smaller than the other, right? And it's just, things aren't symmetrical, which is very prevalent with me, and actually was one of the reasons how I ended up in a lot of the situations I dealt with. So number one, a lot of people get kind of curious. What was the first symptoms that I had? So the first symptom that I had, probably going a few years back before we found this, that I could probably attribute to that was a burning sensation in my mouth, on the left side of my mouth. Like, I just ended up getting a burning sensation, and then it sort of chilled out, pun intended, into more of a numb feeling where I just felt like I lost some of my mouth feeling, and I did research on that. And of course, it led me to something called burning mouth sensation. You come across the biggest problem with these sort of things, and something that I can't stress enough. Western medicine, I can't comment too much on Eastern, but Western medicine is set up under the paradigm of hooves equals horse, hoofs don't equal zebra. Basically, what they're getting at with that sort of statement is that you present your documentation, your literature, your potential care plan, I suppose, if you're creating a template, that it would apply to here. But most things in medicine are sort of tailored to the most common likelihood, right? Which is great for most people who fall into that. But if you fall into a rarity, like I do, just understand one of the reasons it sucks to be a rare case is the literature isn't made for you, right? It's made for whatever is going to give them the best rate of returns on clinical outcomes. And that's just not me. Not me on almost anything. Again, we'll go through it, but almost everything that happened for me, I was an outlier. So this was so again, back to the original symptoms. So burning mouth. And then the next one after that, I would say I had one morning that I woke up where I was incredibly dizzy. I'd say maybe about a year and a half after the mouth thing. And it was the sort of dizziness where it didn't matter if you were laying down. It didn't matter what you did. You couldn't close your eyes and just make it go away, right? It just was this constant feeling of dizziness. And it just felt like my head did not know where it was at. It was very uncomfortable. But I sort of brute forced through it. Lasted maybe a day and a half. It was the worst for about 6 hours that morning. But I had attributed that to medication side effect because I had just started on Lexapro, and that's what I thought it was. Right? I just thought, oh yeah, Lexapro can cause dizziness. So and if you bring that up to your physicians, that's what they'll say. Oh, well, you just started Lexapro as a side effect. Again, horses, not zebras. That's what they're going to tell you. They're going to pick the obvious thing and sort of stick with it. So, again, if there's something that I would impart upon people to understand when it comes down to their own health and their own things that they need to be concerned about, just understand that, right? Understand that they're going to push towards the most common thing. They're going to latch onto that, and they're not going to push any further unless you make them, right? And I'll talk about the ways that you can make them push. So this is a good example. So this would be the first point in which I shouldn't be here. And this one is totally preventable. And what is it? It is the actual advancement of the tumor. I'm going to see if this allows me to actually edit in the screenshot. Kind of will. So what we'll see here, I just want to get a markup. So you see here is this is that's the brainstem, right? You can see that it's already curved. So that's not where you want to be. That's already not in a good spot. Now, possibly some of this is the pons, the back end of the pons. But we can see here with like the gap there, that it definitely has some movement. So in my case, yes, the brainstem had already been displaced. I have another one that I'll open up here in a minute to sort of show you a better example, a better angle, I suppose. So also, yeah. So mine was pretty advanced, right? So it was already kind of ready to off me. And it didn't matter what symptom I reported to my doctor. She never took it seriously. She never evaluated things together, right? So after the dizziness, I had a couple of bouts over like a year of where my left ear would start to hurt like a lot, but in like waves. So it wasn't like intolerable. Might have been. I can't totally remember, but I do remember it hurt, like a really bad ear infection. And then, but it'd be in waves, a few seconds, and then it'd go away and come back maybe a couple minutes later. And that lasted for maybe like an hour. And after the pain went away, there was this constant like microwave chime. It sounded like the microwave was done, which is a really weird thing to hear. And I already have tinnitus from my military service. So, this was something different. This was just like every, I'd say probably once a minute, give or take, sometimes sooner, sometimes later, there would just be a chime sound. And then my ear was extremely muffled, right? And so I had thought that I just had, because I've had earwax issues since I've been a kid. So I just figured that, my ear needed cleaned out. So, I did a flush, cleaned out my ear. And the problem persisted. So, I reached out to my doctor, told my doctor. She took a look and she said, well, I can see some fluid there. So, it's just an ear infection. So she ended up prescribing meclizine, which is, meant to sort of deal with dizziness. And an antibiotic to deal with the infection, and sent me home. After about a week of being on that, my ear was fairly normal again, as far as I could tell. So, I believe that was the case, and I left it at that. And then things started getting progressively weirder. The next thing that I got was occasionally on the left side, I would feel like this sort of like, when you're like upside down and you have your blood draining to your head, I'd have a little bit of that feeling. And after that feeling, I would hear like blood flow or my heartbeat in my left ear. And again, I brought that up to her, and she sort of came back with, it's just a really bad ear infection, right? Sometimes when you have bad ear infections, you can hear echoes and other things in your ear. And, again, we as people want to believe the most benign outcome because we don't want to lean into the implications of the more serious stuff, right? So you're quick to kind of accept that. My gosh, it's okay. It's just an ear infection, not a big deal, nothing to worry about, right? And we'll tell ourselves that to placate ourselves as much as I did, and kind of left it at that. But it would keep coming up over the next year. And then eventually it got to the point where it just didn't stop. All the time I was hearing blood flow. All the time I was feeling pressure in my head. So that was always kind of like concerning, but she said there was nothing to be concerned about. Okay, so fast forward to it's time for my annual physical. And I missed my annual physical just because I was busy. And I had recently been doing various home exercises with my fiance. So I started running again, started doing a lot of different things to the point where I was feeling really good. I was feeling better than I had felt in years. So, I hit him up and I was just like, with the security message, look, I missed an annual check-in, but I don't think I really need it. Right. Because I'm feeling great. Right. After I said that, I was still bothered by the ear situation. Like, I don't know, something about it just told me I should not accept it's an ear infection. Like, this has been going on for years. At some point, I even reported back to her that, my heart rate was pretty low and that I was, decently in shape for my age. You know, I went for runs and stuff, but I wasn't a marathon runner. So my heart rate shouldn't be in the mid to low 50s. And there was a lot of different reasons I thought that might have been. I figured, you know, the current numbers of 60 to 100, that's probably based upon clinical numbers. You know, people aren't walking around with sort of ambulatory sensors on them judging their heart rate. In the past, we are now, right? You know, that watch, you know, it's telling me my heart rate's low like that. So, you know, I'm sort of thinking again as an engineer, I'm thinking, well, we've probably based the literature and the standards off of in clinic measurements. They're not based off of at home, where you're far more comfortable, you're far more chill. You're in a state of rest that they're not going to ever take your heart rate at. So it was easy for me to talk myself out of it, but I still told her. And of course, her response was, well, you know, the good news is a lower heart rate means you're going to live longer. And if it gets bad enough, you know, then I'll send you to see a cardiologist and get, and make sure you don't need a pacemaker, right? Because your heart rate, there's a lot of reasons your heart rate can drop. It can drop for, most common cause I would imagine is probably electrolyte imbalance. Because obviously if you have electrolyte imbalance, your blood pressure will do different things and your heart will try to compensate for it. As well as I think if you're not removing potassium from the blood frequently enough, it'll slow your heart rate down. It's actually one of the ways I believe that they sort of, one of the first symptoms that they notice when there's concerns about your kidney, right? And I believe concerns over diabetes. So it is, I think what ends up happening with early onset diabetes is you're urinating a lot to remove the additional blood sugar from your body, and all that urination is depleting your electrolytes, right? So then you don't have enough potassium or enough sodium or both. And then maybe you're overcompensating, right? It's called balance for a reason. So anyways, that should have been a sign for her. Excuse me. But it wasn't. It was not a sign for her. She did not pick up on it. That should have been the final, okay, there's something going on here. That should have been tied all together, red flag, let's do something. Now, I do plan to do a much larger and thorough video about the VA and the tragedy that is the VA. But that's for another day. But this was one of the first tragedies of it, right? That I had done everything that they tell you to do, right? Let your doctor know, fill her in, keep her aware. The only thing I might have done wrong, and I didn't even do it wrong because I ended up following through with it, was not going to my annual physical that year. But because, that these symptoms were still ongoing and I wasn't receiving answers that made me comfortable, I started to do research on this. And it was just, basic research. But what I did is I avoided the usual pitfalls, right? I didn't go to WebMD. ChatGPT was around back then, but it was at early stages. I didn't look for these shortcuts because I sort of was feeling like one is repeating something that we know doesn't necessarily always work, right? Anyone that's used WebMD knows that you can say, "Oh man, I got a weird pain in my knee," and you go look it up, and it's everything from a sprain, a strain, a bruise to cancer. It's almost always cancer, right? So I just didn't want to fall into that trap of either over stressing it or under stressing it. I wanted something a little bit more tailored to what actually the problem was. So I started looking up actual medical journals, actual published papers. And what I did is I came across an article. It was a diagnostic article. Couldn't tell you who published it or where it's from now, but it was an article that sort of was talking about ear flow, like hearing blood flow in your ear. Yeah, ear flow. And so that the medical term for that is pulsatile tinnitus. So it's a little bit of a different type of tinnitus, right? It's more specific that you're either hearing tinnitus in sort of a pattern that sort of sounds like a heartbeat, or you're actually hearing your heartbeat. And what's interesting is when you look that up, the first thing that comes up is like schizophrenia or some sort of mental health issue, right? That you're imagining this, it's not real. I used to joke that, for so many years, I would tell people symptoms of my brain tumor and they would tell me, Yeah, no, it's just in your head. And then obviously with it being a brain tumor, like, see, look, told you it was in my head. Uh, or it's the one thing they were right about. It's like, look, see, we told you it was in your head. Yeah, right. Uh, but also one thing that people do when they have brain tumors or tumors in general, I guess they name it. So I named mine rent free since it'd been living in my head rent free for who knows how long. So just a couple jokes. But anyways, where was I before I went off track there? Oh hell, I don't even remember. Anyways, the diagnostic article. So, most articles will tell you that. And I kept coming across that, the patient might be suffering some sort of hysteria or something to that effect. And, so the first thing the article said is like, let's verify that you can even hear it, right? Can the doctor hear it as well? So they I can't do all that stuff. I don't have a stethoscope, nor does it matter because I'm hearing it, right? I don't have a third party to listen in. Okay, so skipped over that one. So the next thing that I ended up doing was coming across within the same article. It then said, well, push on your ipsilateral, so same size, right? Contralateral will be opposite. So push on the ipsilateral jugular and see if the sound goes away. And I did, and the sound went away. And I was like, oh shit, what the hell? Cause and effect, right? Like do that, stop the blood flow, and suddenly I'm not hearing it anymore. So, if that was a positive and that actually happens, then it pushed towards, I want to say it was like an 80% chance that it was venous stenosis of the sigmoid, which is the vein that feeds your jugular, which is why, blocking it so blood can't come out of your brain will stop the sound. A high rising jugular bulb, which I'm not exactly sure what that is. I think, again, looking at this image, I think that has something to do with down here. There's some sort of structure that can sit too high. I'm not too sure on the specifics there because there was no reason to. And I want to say that was like around 19, 18% chance it was that. And then a less than 1% chance that it was a tumor, right? So of course I'm, getting 0 horses. So I'm not thinking it's tumor, right? I'm thinking it's venous stenosis. And that's scaring the shit out of me. I'm convinced to the point I've already started to look up like what happens when you have venous stenosis. What do they do? Oh, they put a graft and a shunt, not a shunt. I have a shunt. They put a stent in your brain to open up the blood vessels. It's not a big deal. So I'm not as panicky about it, but I'm still panicky, right? Because this is your brain. And there's something wrong with it. So stenosis is a narrowing of a blood vessel. It could happen just because the vessel itself is shrinking, or it could happen because the movement is shrinking because you have plaque or something else. Osteosclerosis has built up inside there. So regardless, you're not getting the right amount of blood flow. So again, I'm absolutely convinced this is it. Around that time, I started having some weird stuff going on in my eye that's still kind of there. And there was some other thing that I sort of carried with me, right? So I created this little like toolbox of symptoms, right? That I was going to bring to the doctor on my annual and really push for something more than it's an ear infection. And so I did. And, she went ahead and she said, all right, well, we'll get you, I think it's an MPV or MRV. It's basically an MRI where they just look at the veins, right? Like they're not looking at the tissue. They're just going to run contrast and look and find your veins. So I went down to the hospital. It was the James A. Ailey Hospital in Tampa. I went with my fiance early morning. We ended up going to the Women's Center because that apparently is where they had one of their main MRIs there. And what you have to understand is MRIs they're common here in the West, but they're not overall common. They're incredibly expensive to manufacture and to run. They use a tremendous amount of power. And that's one of the reasons why you don't get like routine MRIs, because it's not like it's radiation, right? You don't want to have too many CT scans, because if you have too many CT scans, then radiation, you're going to cause a problem. So you would wonder, why don't everyone just get a full body MRI once a year? Well, it's just price. It's just, that would be far too expensive to do at least 360 million MRIs once a year. So you have to have a medical need, right? And so, you know, I was able to reduce the medical need over concerns of stenosis. And obviously I had other symptoms that it can bring, right? Not one or two symptoms, but multiple. And, you know, I pushed really hard for it. And she sent me down there with orders to get it. But when I was talking to the tech, he says, yeah, you know, I sort of explained the situation to him again, because, you know, so what are you concerned about? So again, at this point, if I'd been like most people, I would have just walked in and just said, oh, you know, venous stenosis, yada, 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 right? And just followed this sort of path laid out by the doctor. This would have been, again, another opportunity for me not to survive, because we would have never found it, because we wouldn't have done the right MRI. Because the veins they would have looked at would have been down here, right? Down my neck, or up here on the side of the head. They wouldn't have scanned in this manner, right? And I saw those, the MRIs that I was supposed to have the images, and you know, they're really trippy, because they can sort of separate your vein from the rest of the tissue. So you just see this vein sort of squiggling out there. But yeah, so I talked to him, and my concerns were, and you know, he said to me, look, you give me an extra 10 minutes after we put the contrast in, and I'll do a full brain scan. Are you okay with that? Yeah, let's do it. Right. Cause I'm serious about this. I want as much imaging as I can get. And so we do the images, and boom, what do you know? I'm the 1-2% of the reasons why you would hear that. So the next image I want to show is one that probably illustrates this a bit better. So this one here, I don't know why it opened it up in Paint, but it did. So this one here does a good bit better job of illustrating a few things. Number one, we can see the asymmetry, right? Let me grab my marker. See how, oh no, that's not a good color. Give me what's going on here. Why am I okay? I have to have this, then give me a different brush. Give me something thick. And, oh, that's probably a little too thick, but it'll work. Maybe this natural pencil. All right, technical difficulties yet again. All right, this works. I'm there. All right, so we're gonna grab just so it shows up real well. So this right here, that is my sigmoid on that side. Now, if you notice, here it is over here. So this is left and this is right. And as we can see, the left side is massive compared to the right side. So that's the first thing that we notice, right? Second thing is, because the tumor is pushing this way, it's causing this part of the brain, because it's up against the wall here. It has nowhere else to go. So it's actually moving in this direction, right? And right here is my ear. So now you have a very large blood vessel sitting next to my ear. Now, is it, any wonder that I can hear my heartbeat? No, now it makes sense, right? Yeah. That makes the anatomy makes sense. The physiology makes sense. The cause and effect makes sense. You don't have to be a doctor to understand that this is why you're now hearing blood flow, and why some of the things are happening the way they are. Well, what isn't happening was also quite fascinating. I didn't have any of the typical symptoms. Well, I would say nothing chronic or persistent beyond the blood flow. And that was a recent addition. You have to understand, with the tumor like this large, that's been growing a long time, right? Like, this didn't just pop up that year, right? This had been going on for many years. Maybe it's the slow nature of which that gave it the ability to sort of go unnoticed and not to be aware of it, because you do things without realizing it. So for me, I used to be very physically active, right? I used to do martial arts. I used to do a lot of training, for a variety of different things, bodybuilding, cardio, all kinds of things in my 20s. I was very, very physically active. I was also in the Marine Corps. So I did all this stuff, and it kept me very active. And because this is growing slow, it's slowly affecting your brain, right? Slowly moving it. And that slow movement process is giving an opportunity for your body to adjust. And if your body has an opportunity to adjust, well, you're less likely to notice these things, right? It's that slow, gradual change that you're not going to notice, especially if you're doing things that is naturally compensating, right? You don't know it, but the symptoms that you should be experiencing, you're not experiencing because your training and your lifestyle is compensating. So I should have had horrible balance. Now I had noticed my balance wasn't as good as it used to be, and I just sort of figured I wasn't being active enough. So what did I start doing? Well, like I said, I started doing these home workouts, these more cardio intensive things. I started running. I was running, 1 to 2 miles a night, sometimes, 2.5. Sometimes twice a day. Like I was being really physically active to sort of make up for this stuff. And that hurt me, right? Like that hurt me in the long run. That allowed this to get covered up. So yeah, I think this illustrates it pretty well. So right here are the fourth and fifth ventricles. These were also blocked in my case. Well, this one definitely was. I mean, you can actually see how this is blocked. They get much larger. This is like a very low slice, so probably about like here. So if you go higher up, those get quite a bit bigger. They're like, I would probably say like, so these sit in the cerepontine angle, right in front of the brainstem, right in front of the cerebellum. And they produce spinal fluid like the rest of them. You have multiple ones, and we'll see some more here in a minute, where they produce spinal fluid. And this being in the way was actually now restricting the outflow. And obviously it was causing brain trauma anyways. So between the two of those, I was having excessive intracranial pressure as well. And that's why I was feeling like it felt like, I was upside down and my blood was flowing into my head. Oh yeah, because the spinal fluid cannot escape. So I've heard a pretty interesting sort of, I can't remember when you have a model that's a three-legged model, right? Or like you have like a triangle, right? And you can be right in the middle and have a little bit of, you have that one attribute, another attribute, right? So in this case, your attribute is going to be brain, right? Over here, it's going to be blood pressure. Just that's horrible. And over here, we'll say this is spinal fluid, right? Do spinal fluid is blue. This is going to be pressure, and this over here is your blood, right? Or your brain. So this overall represents intracranial pressure, right? So if you're right in the middle, then your pressure is good, right? This is good pressure. This is where you want your pressure to be. But if your pressure starts to go up, something has to compensate, right? So if you have high blood pressure, right? Well, okay, the blood pressure is now going higher. So now you have to compensate with one of the two. Obviously, you don't want to compensate with the brain. You want to compensate with spinal fluid. So what does your brain do? Well, your brain then begins to increase your blood flow to try to relieve the pressure, because your brain thinks that this is a blood pressure issue. So initially, it's going to try to increase your heart rate. It's also going to try to address the spinal fluid, because the way spinal fluid works, it is produced in your brain, travels down your spinal column, and it's reabsorbed into the bloodstream. I sort of reverse it. Sorry, it slows your brain down. Your brain slows your heart down because it thinks that the blood pressure is the problem. So it wants to slow your heart rate down in order to lower your blood pressure, right? So, I think they call it Cushing syndrome. So, it could be a sign of a lot of different things. But number one is definitely, if you have very low blood pressure or not blood, God, Lord, what is wrong with me? If you have normal, I think, to high blood pressure, but a low heart rate, that's supposed to be a flag for a variety of different things, including intracranial pressure. That should be the top of the list. But again, my doctor didn't do anything with that. Even though the history is there, right? All the notes is there. I have a history of unusual blood pressures. I've told her I feel pressure in my head, told her I have headaches constantly. All the things were there. Low heart rate. This all should have been combined together into a nice, neat diagnostic package that says that either I need to talk to neuro or I need to talk to somebody, right? But that never happened, right? So anyways, if your spinal fluid goes too high, well, then the blood pressure has to go lower, right? So you would expect this to go lower, right? So a drop in blood pressure could be this. And again, all these have to compensate, right? So this is the one where if the pressure gets bad enough, this is the next thing to compensate, and this kills you. So what happens here is you sort of decapitate yourself internally. It's a horrifying thing. It's what happens when people have very serious head trauma and they don't get medical care in time, where either they're going to open up the skull, they'll relieve some pressure. The people that are, you hear about them in a coma and they have a brain bleed or something. And, I had a brain bleed. We'll talk about that though. And so what ends up happening is cranial pressure goes up. And the way it kills them is it will herniate the brainstem and the cerebellum. So it will quite literally start to push your brain out into your spine. The pressure will push. And that's not good. That's not a good way to go. And obviously in doing so, it destroys that area of the brain and it effectively sort of decapitates you, right? Decapitation is severing the spinal cord effectively from, it's doing a lot of things, but the main thing it's trying to do is sever your brain from the rest of your body so it can no longer control that. And then turtle kick decapitations do the same thing, right? Your brain's no longer connected to the spinal cord. And much you can do with that. I mean, maybe one person in the history have ever survived that. I remember reading literature about a brain herniation and it saying something to the effect of, the patient, this occurs, the patient dies. You lose the patient. But it then had, I don't know if it was an asterisk of, or in very extremely rare cases, they lose all motor function. I can't imagine, and they go into basically saying you can no longer move and you're either in a coma or you're not. Basically meaning someone's going to probably pull the plug on you because you're probably not going to wake up and you're probably not going to move. But for some reason, the brain is still sending signals to the rest of the body and everything is still functioning. I don't know a whole lot about that because I'm going to go too deep with it. But anyways, regardless, the bottom line is there was enough here that should have at least got me talking to someone who was a specialist who would have at least eventually recommended to get an audiogram. And an audiogram is where, there will be certain signs. They call it cookie cutter hearing loss, right? So it looks like someone took a bite out of the, you have your audiogram, right? They do little things like this, right? And then, they'll draw the line. And so these are each different frequencies, right? And how well you scored, right? So there'll be a graph like this. And so they'll call it a cookie bite or something like that, where essentially the middle part, your middle frequencies are terrible, but these frequencies are still fine. And then they combine that with your other ear where you're not having problems. And if it's abnormally good, mine was already showing kind of superhero level hearing. Those are warning signs, right? That means that something is happening to this ear. This ear has started to compensate. This needs to get investigated by a specialist, by an ENT specialist. Again, none of that happened. So from there, and you can see why this is going to be a multiple point video because we're already closed. But it is what it is. I think it's a very important subject. So, however long it takes, we'll do more parts. That's fine. So yeah, I mean, we're kind of mentioning a lot of the same stuff here, right? What causes it? Again, you can have these notes. I wrote these up a little bit ago and sort of stopped myself, even down here where I started kind of writing my story. This won't be bad to keep me sort of on track, but I'm already fairly okay at this stuff to begin with. So we might be all right. But I'll give you a copy of the notes if you're interested. I mean, this is all readily accessible stuff. It does take a little bit of looking. I think one of the things where people get sort of freaked out and they start, sort of having their own panic attacks and is, again, they don't have MRIs. Most people probably never had an MRI of their brain. Therefore, you don't know what's going on in your skull. And something like what was happening to me could be about to kill you. So that's the way, medicine is. It sucks. But that is it. And The likelihood, though, of you having this is so incredibly low. If I remember correctly, the number was like 1 in 125,000, give or take, new case. That's the per capita. I would say like 3,000 cases worldwide are diagnosed every year. But obviously, if a net new diagnosis of 3,000 every year, plus there are people that currently have it in a variety of different stages, then that adds up, right? You're not alone, but it's not common, right? Largest support group I found on Facebook for this particular thing was rocking about 9,000 members. And that's 9,000 that included pre, post, op, people that worked in the area, people that were curious about it, whatever, right? That's actually a very small group, all things considered, especially like if you found out you have this, the first thing you want to do is talk to people that also have it, right? Learn their experiences. So why am I mentioning that? I'm mentioning that because if you're interested in this specifically for vestibular schwannoma situations, sure, yeah, here for you. I think that this is going to have the most value to you. But I think this is important information for anyone to understand how the medical world actually works. And when you actually need them, how quick they won't be there. The moral of the story, even at the start here, right? We haven't even got into the real meat and potatoes of what craziness went on. So I guess the first episode will just be focused on the initial diagnosis and how we got there. And the second episode would be the first surgery. Third and maybe fourth episode or parts will be a breakout of all the different complications I had. Here. So if I had relied on my primary care physician, I would be dead. Now, is that a VA thing? Definitely yes, because I can prove that. That's a whole nother conversation, though. The part of the problem there, and I think this is a part of the problem in many networks that you're gonna see, the workload is just poorly ratioed. It's poorly managed. It's poorly scoped out. What you end up with is providers with way too many patients, right? And so they're just starting to get to the point they're rubber stamping, especially when you're dealing with primary care, right? Your family physician. They just want you to come in. They want to read your labs or imaging if you had any imaging due, and tell you to get out. All right. You don't get enough time to talk to them. You don't get enough time to bring all the little minor details that can change the scope of the conversation dramatically. And so if you're not being given an opportunity to do that, don't take it at face value, right? You need to build your own diagnostic package, right? And if they're not still giving you time, then you need to go through whatever escalation path exists within that network or the legal system, right? You need, if you have a legitimate concern that you're dealing with something that is serious, or you're dealing with little things that you are worried because it has the possibility of being something big. Number one, don't panic over it. That doesn't help at all. I know someone who, weirdly enough, for me, all my panic attacks were mostly present before all this. For some reason, I found so much peace when I got told I had a brain tumor. It's so weird because it was, I knew something was wrong. I didn't know what it was, and that's scarier sometimes than knowing what it is. At least it was for me. So, if you suspect you have something big going on and you're really concerned and you're worried, don't throw yourself into the panic trap. But I always tried to explain to people, because they didn't understand. So many people, whether it was a doctor, and I must have talked well over 100 doctors, well over 50 surgeons, right? It didn't matter if I was talking to them, nurses, medical staff, support staff, regular people. It didn't matter who I talked to. They all said the same thing. I cannot believe you're handling this so well. I would be a mess. And to me, it was very unusual. That was a hard thing for me to understand, because the initial response I had when I got the phone call, I sort of don't know. My mind wasn't centralized, right? Like there was like a sort of like float, right? Like what does that mean, right? And for about 2 to 3 days, it was this sort of almost surreal experience. I didn't feel like it was real. obviously I couldn't think about much else other than that. But at some point, it sounds so cheesy, and I don't even like talking about it because it sounds so cheesy. It makes me uncomfortable. Me and my fiance ended up going out of town that week. At the time, she was my girlfriend. The whole reason she's my fiance is how much of a warrior and how awesome she's been dealing with this and supporting me through all this, because it's been a battle and it's still a battle. To me, there's no greater test of a partner in life than that. She never backed down, never sidestepped it, never, I mean, I'm sure she calculated how this was going to impact her, but she's never made it about her. For the most part, she's always looked out for me, and I could ask for nothing better than that. She's been vital to me surviving this. So that's something else. Get a support network. Get somebody that can be there for you. I cannot imagine what it would have been like to do this by myself, because it was rough. I mean, there were, weeks that I was in the ICU that I didn't see her because she had her own responsibilities. It was busy. And so I did have to learn to kind of live, with just me and the medical staff. But, having her there, being able to talk to her, sharing in this sort of journey, if you will, together makes a difference. So a support network is extraordinarily important. And if you don't have an organic one, have an artificial one. Go join a support group for whatever your ailment is. Find support somehow. It makes a difference. At least to just know you're not alone. Something that you're dealing with is not unusual to your case. That's huge. That is huge. So I would definitely recommend the support network. I'm trying to remember where I was going with the other advice. Oh yeah. So, learn your network, right? Learn what options you have for escalation. Learn also the process of whatever treatment you have to get. So for me, I learned that, this particular surgery sort of boiled down to three major options, right? The first one, I think, I listed here. So you have watch and wait, right? And so if your tumor's small enough and it's not causing a lot of symptoms, they sort of just monitor it via MRIs. I want to say every 6 to 12 months, depending on if it's growing. If it's not growing, they may throw out more time than that. If it's aggressively growing, and sometimes they do grow aggressively far faster. There was a guy in my support group who he had gone through multiple surgeries to resection it, and it just kept growing back. And then eventually they figured out it wasn't a schwannoma, it was a meningioma instead, which is a meningioma is the meninges that cover your brain, right? It's a tumor of that, and in that particular case, it is still fairly rare overall, but it is more common in the serotine pons angle than a schwannoma. So whether or not his was a schwannoma and then became a meningioma, it's hard to tell, right? Because once you resection it and it's, you remove some of the mass, you've caused damage and trauma to that area, the body's going to do various different kinds of things to sort of heal. And obviously the tumor is not something you want it to heal, but sometimes they will heal if the blood flow is still present and, that tissue is not dying. It will continue to try to heal and regrow because the main mutation that caused it over here that causes the protein malfunctions, it's probably not gone, right? It's still there. And therefore it's going to grow back or could grow back. So when they go in the first time, if they can't remove all the tumor, we'll talk about why they can't and some of the aspects around that. But if they can't remove it all, and oftentimes they can't, more times than not, they can't remove it all. And so you'll have to have follow-up monitoring and care. But one thing they should do, and the San Diego program understood this, and clearly, because this is all they do is neuromas and schwannomas, they should cut off the blood supply, right? As best as they possibly can to decrease the likelihood of resurgence. And so in his case, it might have been the first few times he had surgery, he had just a very unusually aggressive schwannoma. And the treatments actually have now caused it to go a different direction. And again, that happens, right? You have to understand your risks versus benefit, right? So a lot of people will instead, in the surgical options, opt for radiostatic or radiation. So you're oftentimes will be presented by, I will call kind of like the middle ground, right? You're going to have the not overly concerned, doesn't require much of you intervention on these sort of things where it's something gentle or soft and not really gentle or soft, but compared to all your options, it's more gentle or soft. And so that can be things like radiation. What's the other one? Chemo, things like that, right? They're not as what they would refer to as radical or aggressive or invasive as some of the other options. And some people just opt for that. But you have to understand there's a risk to that. If you choose to go down that route, that means that doesn't work. On the flip side, you're going to make the other options less likely to be effective or harder to pull off. And so what that means is if you do opt for this, and I was beyond this, I couldn't have this. Mine was too big. Again, the size of mine ultimately was north of 4 centimeters by 3 by 4, I think it was. So the cutoff for radiostatic surgery means you can't have a dimension of it larger than 2.5 centimeters. And obviously I was way past that. So I just couldn't have that as an option. What would I have done back then? I'm not too sure. I think there's part of me that out of fear of surgery, because I'd never had a surgery, never been under anesthesia, probably would have pushed me towards radiostatic. But if you look at that, you see the crazy situation where they have to literally drill holes on your head and mount this crazy looking cage that looks like it's something out of Hellraiser, so that they can fit you into, this extremely advanced alien technology where apparently the whole room moves, zaps the tumor in an extremely precise manner, because obviously they don't. They, suddenly you think you're a carrot and you're drooling, right? Not something you want them to miss on, and that's why they put your head in a crate or cage that doesn't allow you to move. Doesn't matter, you can't move. I don't think they put you under for that either. But it still has some invasive elements. It's still enough where, just scary regardless. So as far as the microsurgery, which is obviously what I had to have, there's 3 major options with this. I ended up having to have the most aggressive of the 3, yay me, and that's the translabyrinth, right? So again, understanding your options is so important. Understand why these options exist. What's their trade-offs? Radiostatic, if this doesn't work, it makes the tumor sticky. It makes it sticky and it makes it less like structurally sound, which makes the surgeries much harder for them to do with less promising clinical outcomes. Not that I'm saying they're going to kill you, but they won't be able to remove as much. There's a higher likelihood of nerve damage. Nerve damage, obviously I have some nerve damage because my face doesn't work as well as it should. And they cut one of my nerves intentionally. The thing about, so a good example, and then I'll try to wrap this just as the first sort of episode here. So the translabyrinth, what that means is they basically cut your ear off, right? And then they drill a hole through the labyrinth, which is pretty much all your vestibular bone structure. Now, there's the bones in your skull play as important of a role in your ability to hear as the ear structure does. So once that stuff is destroyed, you're not going to hear, right? You don't hear anymore. So having that, I knew I was going to be deaf in my left ear, and there was just nothing I could do about it. That was just part and parcel of my situation. Which that reminds me, that was what I was talking about, the minds. Before I go any further, you see how I just said that part and parcel is just what you have to do? That was what I arrived on my 3rd day post-diagnosis. Sort of looked in the mirror one day and I just said to myself, get your shit together. This sucks. It's not fair. There, you did it, right? You're done complaining. You're done saying, woe is me. Now do something about it. Figure out what you need to do and execute the plan. And that was it. After that moment of staring at myself in the mirror, like some sort of cheesy ass, theater moment, I just told myself I wasn't going to lean into the negative. And there was a logic to that. It made sense, right? Because if you're going through anything in life, it doesn't matter what the problem is. I don't care if it's medical or not. If you have a problem that needs to be solved, what does adding to it in terms of toxicity and negativity, panic, worry, all this stuff, what does it add to the problem of value, right? It adds a lot of problems. It makes your problem more problems. So you're just adding problems on top of your problems, but it does nothing to effectively help in solving it, right? There's never been a time in the history of ever where worrying and anxiety made the situation better. It isn't going to happen. What it is going to do, though, is it's going to make you less effective. It's going to make you emotional. It's going to make you even toxic. And then you're going to end up being toxic to the people around you. And then before you know it, you're actually, sorry, I'm hearing a cat scream. We got a new kitten running around with the other herds. So anyways, you're going to be toxic. And if you end up being toxic to the people that you're supposed to be leaning on for, saving your life, and you're putting them in a bad mood because you're lashing out at them. And no matter how hard they'll try, they're people too. They do a great job of sort of compartmentalizing and staying objective about, mistreatment. But at the end of the day, they're just people. And if you're negative enough and mean enough to them, you're going to eventually get to them, even if they're not even aware of it. And that will affect their ability to help you. And again, not even just about medical care, right? If you need to lean on any external person for care and assistance to help you solve a problem or overcome a challenge, and that challenge and problem has made you a shitty person to be around, that's not going to help you. It's going to do the opposite. It's going to hurt you so much. So that was one of the first things that I did. The other thing is, I sort of learned at that moment to stop comparing my life to other people's, whether it was my body, whether it was, what I was getting in return of investment on effort put forth. I needed to stop doing that. My entire life, I'd always felt like, between me growing up abused and, my luck with women, my results with working out, like I never felt like any of it was fair. And I was basing that totally off of how I evaluated other people, right? And what you have to realize is oftentimes you're inadvertently creating a vantage point where you're only seeing the outcomes that are favorable. You're not seeing all the bullshit. You're not seeing the people that have a worse outcome than you. So you shouldn't feel as you feel based upon what you can see. You probably should get a reality check and talk about what you don't see. And then ultimately the way you feel should be based upon yourself, right? Don't compare your problems to someone else. You are not intimately educated enough on someone else's life to be able to do that. Since I've come back to the internet world after all these surgeries, I've become far nicer and far less likely to argue with people in video games. And some people don't understand why, right? You got to troll or someone being extremely toxic on social media. Like, why am I not fighting with that person? Vantage point. I come to the belief that if someone's being that toxic or having that many problems or trying to cause that many problems, they're working through pain. They got their own battle and they have very poor management skills. Is there a subset of those people who are actually just pieces of shit? Sure. But I can't tell which ones are which. So, I don't want to treat everyone as a piece of shit and be wrong because I just, hit somebody who maybe they just lost a kid or something, right? That's going through a very traumatic experience or something, or some minor, right? There are some experiences that are minor that to some people are fucking massive because it's all relative, right? It's the delta of baseline, right? And what I mean by that is, yeah, maybe that person's dealing with something extremely minor, right? In the grand scheme of things, but maybe that's a massive difference or delta from their normal baseline experiences. Their baseline might be that they've had a great, phenomenal fucking life without any real challenges, right? But now, because of whatever, something changed, now they have their first real challenge or inconvenience in their life. That is still the most extreme thing they've ever had to deal with. Is it superficial and sort of tragic, and they're kind of privileged for never having to deal with a major issue? Sure. I can see me argue with you there, but it doesn't change the fact that to them, this is a dramatic thing. So I've tried to be a little bit more empathetic about those sort of things, primarily because you just don't know the battle someone's fighting. And also there's a self-preservation element to that. Many people have been killed in a moment of extreme passionate fueled violence because they're having a bad day and they decide, to be toxic, or maybe they, got some bad news from a doctor. They decide that gives them a warrant, a justification, a license to be a prick to other people, forgetting the fact that you don't know if that person you're being an ass to is dealing with something 10 times worse than you. And they were barely hanging on, and you were the one to push them over the limit. It's happened. I've seen the cases. I've watched videos, horrible videos where 30 seconds of somebody running their mouth led to 2 people losing their lives. It's just it only invites negative. It only invites problems. There's not a single time in any area that I can think of, in any history that I can think of, where being negative and being an ass has improved the outcome of anything. It just is what it is. I mean, it doesn't suck that we have public figures and celebrities who can be asses, who can be complete pieces of garbage and still be wildly successful. Yeah, sucks. Yeah, fuck you money. And that gives them the ability to be that way. But they'll either change or through one reason or another, or their negative machinations will eventually lead them to a problem where no matter what their success level is, no matter their money, they need somebody else, right? They need somebody else, and there's no one there for them, right? Unless, you're going to suddenly pay for, a stranger to come sit bedside with you while you're potentially dealing with a life-ending situation or whatever else. Those people are going to end up lonely, and they're not lonely by happenstance, right? It's lonely at the top. No, it's lonely at the top when you kick everyone off of the top, right? When you say, no, I'm gooder than you. I'm better than you, right? Like I need to associate with people at my level. I'm an elitist, blah, blah, blah. Yeah, you take that route, then you'll be lonely. And I mean, if you're fine with it, then by all means, do your thing. But again, I couldn't imagine going through this alone. Having somebody there, having that support network is crucial for things beyond what can be solved through material wealth or material resources, access, or even knowledge, right? There's just some things out there that you just need someone to talk to, and that makes the difference. And you want to preserve that possibility, or make friends. I made friends with several of my neurosurgeons, not just because I actually contributed, and we'll get to that. I contributed to my actual surgical plans, solved some problems for them. Okay, we'll talk about it. But because, I just had a great attitude. It was actually the point where the same neurosurgeons that I became friends with, who I would see on a daily basis while I was in the ICU, they initially kind of gave me stank eye because they couldn't understand me. Like, what is with this guy? He's so jovial and goofy and cracking jokes and having a great time. She doesn't know what's going on, right? That's how they would look at me. They would think that there's just something not mentally right with me because my response was so, as the kids say, out of pocket, right? It was non-textbook. And that's fine. Like, that's just who I was. But, it got to the point when I was in the neuro ICU, I was in there for, a couple of months, and, overall probably spent half of 2023 in the hospital. It got to the point where, like, my room was always the place, no matter what unit I was on, ICU or step down, didn't matter. Nurses loved to come to my room. They would come hide in my room, right? Because I don't feel like doing anything. I'm going to go hang out with, him. He's funny. He's enjoyable. There's a few different reasons for it. It wasn't just my personality. It was also, I was one of the few people conscious, right? Most of the people in neuro ICU are unconscious. So it's pretty weird to be a conscious person. So there was a lot of things in the ICU, comforts that they don't offer because they don't expect you to be awake. For instance, bathrooms. There was no bathroom where I was at, and I was hooked up to some stuff where I couldn't just leave, right? Like, I mean, it took a team of people to move the machines and the tubes that I had going on when it got as bad as it got to, which again will be a different part. But yeah, just focusing on the diagnosis and how to interpret it. You have to advocate for yourself. Don't be scared of a doctor, right? don't become a pontificating know-it-all, right? What you should be with your doctor is a partner, right? You need to collaborate with them. And if they're not giving you the time of day, you need to figure out how to get there. Don't accept some weak answer. Don't also accept the first opinion if you don't necessarily agree with it. Because again, going back to this, I have a story about that. And that is my second, I believe my second opinion was with the Mayo Clinic. And I went there, and at this point I was already fairly, dove in head first into educating myself on these sort of things. I actually watched the surgery so many times on YouTube. Not necessarily something I would recommend if you can't handle it, but I really wanted to know what they were going to do, and I actually ended up watching a surgery by the program where I went and had surgery, the exact same surgery I was having. So I knew how it worked. I had a pretty good idea of what I was in for. So I was able to check people, right? So I ended up at the Mayo Clinic, and I first see the ENT, the neuroenterologist, the surgeon. So the the ENT surgeon, they make entry, right? They go through all the ear structure, and then once they get past like a certain barrier, neuro takes over, because now you're dealing with more the brain. Whatever surgeon is there is based upon where they're working. Anyways, so aside from that, once you see ENT, we had a couple hours, and we're way out of town at this point. So I think we just hung out for a couple hours in like the lobby waiting for my next appointment, which was with neuro. So, I ended up meeting this guy. Gosh, he must have had like 8 names. I even told him, like, do they have like something shorter for you? Because it was just a wild. He was from Brazil and just had a ton of names. And I'm not gonna lie, I was a little bit concerned, when I saw that, his education came from Brazil, right? Because I'm not, at the very least, I'm not educated on the standard Brazil. I have to find out, are they held to the same sort of standard as American doctors? I have seen situations where people have come from like Haiti as doctors, and they end up here, better situation to be a doctor here than back on their island, which I understand, but and I don't know why there's a behavior element and then there's a qualification element. The qualification element was definitely a concern, right? If you're seeing a doctor in the United States where Western medicine is pretty good, it's not perfect, but it's pretty good compared to somewhere else, and that somewhere else doctor is now sitting in front of you, it's not racist and it's not, politically incorrect to take that into the calculus, right? Your desire to virtue signal may cost you your life or cause you to have a serious handicap for the rest of your life. So you need to evaluate these things and just, ask yourself, okay, does, a doctor from this particular university in Brazil, do they have this? Does that university have the same standards, right? Then as a doctor, how many of these surgeries have they done in the United States? Because, I watched a couple of these surgeries get done in India, and they are far more aggressive with it. I wouldn't want to have surgery over there, right? Like, they're not as graceful and as gentle, so to speak, when they're doing their surgeries. And so how much of that potential philosophy are they bringing with them into the operating room, right? Are they adopting the expectations of how we work here, where, maybe patient comfort and quality of life is primary to clinical outcome, the clinical outcome being secondary. Actually, if you really evaluate it, they're both kind of interconnected. If you're worried about quality of life post-operatively, that's going to play into your clinical outcomes and improve them. But do they pay attention to stuff like that? If they don't, then you probably shouldn't see with them, right? So anyways, as I was talking with him, he ended up being the second person to mention fascia. And I found that very, very weird, because according to the literature, once you have a tumor as big as mine, you don't do these two. You do this. And again, every treatment you have has trade-offs. So the trade-off with the translabyrinth you lose your hearing, you sacrifice the hearing, but you sacrifice it so that there is a much, much lower probability of damage to other nerves that will really affect quality of outcome. So you have the nerves that are involved are cochlear nerve, right? So, that's one thing that could get potentially damaged. Obviously, at this point with the cochlea, which is oftentimes where the tumor starts, on the cochlear nerve, you're losing your hearing anyway. It's probably less concerned about making that. In my case, they actually cut it. They severed it. Not sure I totally agree with that, because that sort of took the ability to get a cochlea implant out of the equation. So yeah, they took that choice from me. The reason they did it was their belief was that if they sever it, they decrease the likelihood of phantom tinnitus, which would be phenomenal if it actually worked. It didn't. So the only thing I hear in this ear is a constant whirling and screaming sound. It's like tinnitus, but times 10, since there's nothing else that my ear can hear. And that's a wild thing, knowing that my ear's not even hooked up and I still hear tinnitus from it, right? And that's primarily because my brain is producing it, right? That's a phantom sound that my brain is sort of interpreting. For whatever reason, it's not getting signal anymore from my ear, and it's kind of figuring the rest out. Anyways, so that's why you go translateral, right? Sacrifice hearing so that you don't damage the facial nerve, the mandibular nerve, which is known to affect your swallowing, and your trigeminal nerve, which the trigeminal nerve's why I probably lost feeling in my mouth, because that's where that nerve seems to work. And that ended up getting usually what happens with it is the nerves are getting stretched, right? As the tumor is growing, it's stretching the nerves out, which is, causing problems eventually. It could rip the nerve, damage the nerve, keep it from working, whatever. So, the mandibular is a very important one to me, because your ability to swallow is so big. There are people who, due to botched surgeries or just damage, whatever the case may be, they're on permanent peg lines, right? So they can no longer swallow. So they always now have to be fed via tube. Walking around normal people for the most part, but when it comes to eating, they have a little like hatch right here leading to their stomach, and they have to pop that bad boy open and eat that way. They can't swallow. So, it's too dangerous for them to do it any other way. Possibly fluids are not as big of a concern, but that's going to play on you mentally, right? Like you're going to, there's a dramatic increase in depression for any kind of bariatric bypass surgery, because people that generally tend to need it have a very unhealthy relationship with food. And the loss of the ability to be able to eat and savor food, kind of leads them to a deep depression. So I can imagine, never being able to eat again and having to use a hatch to feed yourself just must be so depressing. This particular tumor affects women more often than males. So, there was a lot of young women that, I feel terrible for them, they had all the normal, pursuits that, all of us do when we're young. And now they have to contend with this problem compounded by the potential implications of that. Right. So the one girl I'm thinking of, she was a very attractive girl over in the UK. For some reason, the UK had some of the worst surgical outcomes when it came down to this particular tumor. I don't know what that's about. But she was in a deep depression over it. And you could just tell that, she just kind of got robbed of potential, and it was affecting her personality at a much deeper level. So when I say that, they could always be worse, yeah, that's true. I mean, my complications, and there are many to talk about, almost killed me multiple times and have definitely resulted in some permanent disabilities. But, it all depends on what value you put on them. When it comes down to hearing, right? To me, I went a different route than most people. Most people get upset because, I lost my hearing in my left ear. I didn't, because all I did was focus on the fact that I got another ear and I'm not going to lose access to music. You want to talk about a scary and haunting thought. Imagine, if you will, that you have your favorite song, right? Something that you love. It's moment turns out you can't wait to jam to it. It gives you a certain emotional feeling. You get lost in it. Now imagine you can never hear it again. You will never hear it again. The only place you could ever hear it again is inside your head, where you'll try to remember what it sounds like. And that too in time will fade. And so there will come a day where you will not be able to hear your song ever again, either in memory or actually. And so, yeah, that to me is a big thing, and that's scary. It's terrifying. So I was just so thankful that I ended up with a good ear coming out of it. Now, there's other problems with it. It's such a weird thing having super hearing. It's not a good thing. A lot of people think, oh, wow, you're hearing so good. You do this. You do. No, it's a problem. It's a real problem. Number one, just like if you ever watched like sort of the coming age Superman arcs, whenever his hearing starts going super and he's hearing everyone all over like the city and he can't drown it out. It's driving him crazy. It's kind of what happens to me when I'm in public places at a much smaller scale, right? It's not actually super hearing. It's just I can pick up fidelity at a level that most people can't. And there's so much of it. If you're in a restaurant and you're sitting there and that like sort of background sound where all the voices are sort of amalgamating into this weird sort of like, I don't even know what that is, right? But it's like the soundtrack of a hub of conversation, wherever that may be. And you come to expect it. Well, I don't really hear that anymore. Now I actually hear more of the distinctive voices and the words that are being said layered on top of each other. And it hurts my head so much. And it makes it almost impossible for me to hear things clearly in front of me because those things now have to layer in, even though they're closer and they should be clearer compared to those things. They're not. They're all just about clear on the same level. Matter of fact, they will be less clear on my left side, right? Because I can't hear my left side. So, yeah, it causes a lot of problems. But there are some cool things. Like there are some songs I've listened to where I've actually heard sounds that I never heard before. Both of them could be, well, not both of them, but it could both be intentional and unintentional. Sometimes I've heard voices that I feel like were in the studio because, it was like an affirmation, like, yeah, that sounds good. Maybe it was meant to be there, but it was so low that it's like, maybe they couldn't hear it, right? It doesn't register on, audio software, the ones that I've used, right? You don't see the ping go up on the graph. So the software is not overly detecting it. It's getting lost to the background noise. So maybe they're not aware of it either, because if they can't hear it, how would they know to remove it, right? But, sometimes I also will just hear the weirdest things and, sometimes like auditorial hallucinations. That's super fun. So, it's a battle. It's a struggle to deal with those sort of things. But anyways, what we'll wrap up here with is, just real quick. There's some tap on my cut. So, at what point does it become fatal? I don't know if I mentioned this, but yeah, I mean, the point at which it becomes fatal, this, can definitely become fatal. It was, as you saw in my pictures, it was fatal it turns fatal from what it does to the brainstem, either through the intracranial pressure, because it messes with the normal flow of spinal fluid, or because it actually will eventually grow big enough where it causes damage and displacement to the brainstem, which will then result in no more signals making it from your brain to your heart. Like I said, yeah, I did talk about it, internal decapitation. So mine was there. It was there. I'd asked Dr. Friedman just out of academic curiosity, how close am I to not making it? And he said, not. Yeah, pretty close. We're talking probably months. If it was growing slow enough, maybe a little longer, but we were already there. And remember, I was just told it was an ear infection, and also realized that only having this as an option. So this one right here is actually where they go through the temple. This one right here is where they go through the back of the skull, right? Retro, behind, sigmoid, again, that big vein. I would have had these two as a potential option had my doctor took me seriously 2 years prior when I first started reporting symptoms. Now, I don't know how big it was then because we never did the MRI. But what if most of its growth had happened in those last 2 to 3 years? Those were the years I had symptoms. Never had symptoms prior to that. So maybe it got really aggressive in those 2 years and it grew, 2+ centimeters in that period of time, which put me out of range for these two. which means, I would have had a viable tort act lawsuit that I could have gone after my VA prescriber for loss of hearing because they didn't do their due diligence to make sure that, everything was accounted for, which ultimately led to me having permanent, essentially disfigurement. I mean, I have massive scars all over my head. They didn't really be showing up too well because it's light on. But they're still not really super showing up, which, it's good other than the shunt. So we'll talk a little bit about this. This is, that relieves the pressure from my skull to keep, because I still have pressure issues. Like I said, I had a lot of complications. So this is kind of like my T-New Iron Man device, keeps me alive. It stops working. I got a couple hours and we done. I don't know. It depends on how bad it is. It was pretty bad. Right before they put it in, they tested it. And after 45 minutes, my cranial pressure was critical. So that tends to encourage, I don't have a lot of time if that stops working. But obviously I don't get to do anything cool like have a Iron Man suit. That's all it does. But I do have it. But I am slightly cybernetic, which is kind of cool. But we'll talk about all those sort of things in the next parts. But yeah, probably could have avoided a lot of this stuff. Wouldn't have had the number of complications. Now, I should mention those two things very importantly. It isn't just about advocating for yourself, which can help you have better outcomes and prognosis. But also, I read through my complications and overall the surgery, and every complication was made so much worse, and the very possibility of having the complication was so much higher if you were overweight. And I was about 340, 330-ish around when I got my diagnosis. Now, like I said, I was getting, starting to get active again, but, I wasn't really losing weight. I just wanted to, have a little bit better cardio, be a little bit more active. But I wasn't really losing weight at a fast rate. I think when I got out of the hospital, I was around 315, but I put the weight back on because then I could do even less. But over the last 7 months, I've lost about 100 pounds. I'm at 248 now. Like I said, I was around 340 then. So we're almost at that 100 pound mark. So I took that very seriously. When I read through all that literature and saw, the correlations between obesity and, this stuff turning on you and killing you, I stepped up my game. I have to lose the weight. It's no longer about looks, no longer about performance. Is simply about making it to 80 or 90, right? For at the very least, my family's sake, the family that I'm building, if not anything else. So so we'll stop part 1 here, and we'll start part 2 right after this. I don't know when I'm gonna tape those because these take a bit out of me and don't have a ton of good health, and it's already getting kind of late. So I'm going to wrap this one up.
Hey there, it's me again. Just wanted to kind of leave you with a few things. One, there will be another episode to wrap this up. There's a lot more to cover. Also, bear with any issues that may come up. YouTube and all this is very new to me, and I'm still learning. So again, thanks for watching, and see you on the next one.